Hello, my name is David Lewis, and I'm the chair of pathology at Mass General Hospital. And I'm here to moderate today's session on digital health becoming a pillar, in which we hope to tackle a number of critical issues surrounding digital health and how it's changed during the COVID outbreak. I'm joined by 4 expert panelists today. Dr. Alistair Erskine, the Chief Digital Health Officer for Mass General Brigham. Dr. Adam Landman, the Vice President and Chief Information and Digital Information Officer for Brigham Health. Brooke Lavasseur, the CEO of Arista MD. And Lee Schwam, the Director of the Center for Telehealth and the Vice President for Virtual Care and Digital Health at Mass General Brigham, as well as the Vice Chair of the Mass General Neurology Department. What we'd like to do today is first set the stage for digital health. And from that point of setting the stage and looking at it historically, we'd like to then explore how the COVID-19 outbreak has provided a sort of perfect storm to accelerate its adoption and use. And so what I thought I'd do is begin by asking Brooke to offer some historical perspective on the rationale behind digital health over the past 5 or so years. Brooke?
Sure, happy to. Thank you for having me, David. Arista MD was really formed because in the US, we've been facing a significant challenge around access for quite some time. There is a significant shortage of specialists in the country, and that is matched with this growing aging population that has a lot of complex needs that require ongoing specialty care. So what this has resulted in is patients across the country waiting for weeks and often even months to get the care that they need. You know, this problem with the great imbalance between the supply and demand, again, has been going on for a very long time. But I think now in the midst of this COVID crisis, it's really shone a spotlight on the problem, as well as highlighting how technology can be effective in better allocating our limited resources.
Thanks, Brooke. So that sets up what we hope to explore in this panel discussion. And we thought we'd break it into 4 areas for discussion. The first is what we've termed boosting and innovating, which is to ask the question, what are the digital health models and technologies that have been augmented and developed as a result of the crisis? We'd then like to shift the topic to what we've called PrEP, which is how would we need to digitally upscale all of this activity? And then we'll go on to looking at what are the risks of individual healthcare providers upscaling. What are the risks around things like reimbursement and regulatory concerns and equity? And then lastly, we'll look at assumptions and adaptations that have happened over the last couple of months. So to begin with the subject of boosting and innovating, what I could do is ask Lee to begin commenting on some of the virtual care work streams that have emerged.
Thank you, David. I think one way to think about this is really where could we apply virtual solutions to clinical problems that either were exacerbated by COVID or emerged for the first time. So in the provider-to-provider space, we recognize, first of all, the need for virtual consultations between providers rather than face-to-face. But in addition, really needing to rethink how medical rounds work so that we separate physically providers who were traditionally clumped together on rounds and use collaboration software tools to spread them out, either from home or in the hospital. In the provider-to-patient space, we obviously needed to dramatically ramp up virtual visits, so ambulatory care over video or telephone. But we also understood that we needed better ways to care for our patients inside their isolated hospital beds and hospital rooms. So we leveraged a video intercom solution so patients could have a humane physical contact experience over the iPad with their providers while limiting the use of PPE and personal exposure. Then we thought a lot about monitoring and developing tools for both ambulatory and inpatient remote monitoring to look for concerning trends and intervene early before deterioration began. And to keep people out of the hospital altogether, virtual urgent care was another offering that was ramped up to try to address minor concerns around COVID-related illness or the management of other chronic conditions that were struggling to be met by the existing healthcare infrastructure. And then lastly, we really looked at automation. So automating both using health bots to try to address getting information out through interactive voice response on a triage hotline, to providing web-facing experiences for patients with questions, to finally looking at our own employees and their occupational health needs, all designed in a way that was immediately scalable and could be updated on a moment's notice.
Thanks, Lee. So those are all innovations that have come about, and many of them deal with triaging with the resources that are available. Maybe I could turn to Brooke and ask how you've thought about using e-consults as a triage tool.
Yeah, sure. I mean, it's really top of mind. I'd say that the majority of the conversations that we are having today with our partners are all about reopening strategy. How do we start bringing patients back into the clinic? How do we reopen for procedures again? And at the end of the day, they're looking at, in some cases, thousands of patients that are now in this backlog. So triage is something that we are looking at all the time. How can we optimize a process to really prioritize cases? E-consults are an effective way for specialists to take a look at all of the pertinent information about a patient on a wait list, and to then be able to look at them, and if they have to be seen in person, to mark on the case when this patient needs to be seen to help prioritize it from a time standpoint, as well as it can be effective in directing them often to a different mode of follow-up. So the specialist may weigh in and say, this patient, I want to see them, but I can do it via a video visit. Or in fact, the patient can actually be treated by the primary care provider, but I'm going to recommend a next set of steps or follow-up that the PCP can then execute on. So what's really neat, I think, and Lee touched on so many ways these new technologies are being used, is that we are looking at so many different modalities and that providers are embracing them. So at the end of the day, you really just have to look at what is in your full toolkit and how to appropriately match it with the patient, whether it's video, whether it's asynchronous, or in many cases still an in-person visit that is needed.
Great, thank you. Adam, you've also innovated in this space. Do you want to make a few more comments about particular applications?
Great, thank you, David. I actually want to build on the comments that Brooke and Lee started with. Early in March, when COVID was really starting to spread in the Boston area, we recognized that there was lots of questions from the public, from our patients, even from our clinicians and staff. And so we stood up a COVID hotline that was staffed from nurses from across the partners' enterprise. And this was extremely successful. We immediately had a high volume of callers, but unfortunately there were also long wait times and a high abandonment rate. And so Lee, Mark Zhang, myself, and others started to think about creative ways we might use technology to help offload some of the call volume. And we heard about some of the work at Providence St. Joseph Health System in Seattle, which, as you know, was hit with COVID before us. And they were working with Microsoft to use chatbots or electronic automated screening tools to help triage patients to the appropriate site of care. And so we also talked with Microsoft, and they helped us very quickly stand up our own version of a chatbot or health bot. We stood this up in about 4 days, thanks to our technical teams, and we have so far had about 16,000 users use this chatbot. For those that are very sick and acutely ill, it directs them to the emergency department. For those that might need additional evaluation or testing, it directs them to our hotline to get directed to the appropriate site of care. And finally, for those patients that don't have symptoms and really just needed supportive care, it can reassure those patients and be able to take them off of the hotline. So this was a really nice example where we very quickly stood up new technology tools that worked with our hotline and helped get patients to the appropriate site of care.
So those are all amazing examples of the resources that can be available. With that in mind, let's move on to the next segment, which is to think about the prep stage and what would be the costs and challenges to sustaining this kind of work, and moreover to, as Alistair said, digitally upscale. So Alistair, in your capacity, could you comment about your thoughts on what would be the next stage to digitally upscale?
Thanks, David. I think, one of the key things from a digital upscaling perspective is understanding that, the digital health surge predated the COVID surge by at least a couple of weeks as people were trying to prepare for what was coming up. And, another key thing is that we're still under incident command right now at Mass General Brigham, meaning that, a structure of decision-making, rapid decision-making that was designed to be weeks, maybe months, wasn't necessarily designed to be kind of for years. So I think during that time, it's been really important that we understand what critical capabilities, new critical capabilities we needed to be able to have. For example, to be able to adapt under uncertain times, making changes to digital health technologies on the fly, being able to rapidly deploy surge capabilities, whether they be the way that the hospital is organized that turns one unit into an ICU unit, whether it's a field hospital that needs to be built in order to be able to accommodate surges of patients. We, as you heard from Lee, we also added virtual as a standard venue in the care model. Just like inpatient and ambulatory and post-acute, now virtual becomes another way that people will receive care. And all of this requires a more robust and refined data environment to reduce the amount of time it takes to generate insight from all the things that are occurring at the front line. And I think that it goes without saying that promoting research and innovation and making sure that the things that are discovered at the front line make their way quickly into kind of embedding at an enterprise scale is incredibly important. One of the challenges that we'll run into, though, is with all this work and activity, we'll end up developing some technical debt. And what do I mean by technical debt? I think that there was a number of standard things that occur from a maintenance perspective across the system. We had imagined our 2020 roadmap in terms of digital health technologies that we were going to go forward with. We had existing enhancements to our system, and all those basically went on hold as necessary for the COVID response. And in fact, as we calculate the time away from the standard work that we did, it was ranged anywhere between 15 to 40% of that time. Work needed to be stopped and will need to be resumed. There's work that had been planned that will need to be reprioritized. And then we'll need to rapidly deploy COVID technologies and processes that were done at the point of care, but now need to be done at scale. And all this while capital dollars are drying up, while the supply chain is being disrupted, while responding clinicians return to their day jobs, and then the whole set of digital upscaling is required for staff and for clinicians, but really importantly for patients as well, as we try to think of digital navigators that will need to be created in order to be able to shepherd a number of patients through this new virtual care offering.
Thanks, Alistair. It reminds me a lot of what's happened in my area of laboratory medicine over decades, where individual institutions can't do this alone and really rely on interactions with industry partners and with other academic institutions and other clinical institutions, and that those relationships change over time by necessity. So maybe, Brooke, could you comment on how you see the interactions in the near term, at least, between industry and clinical institutions?
Sure. As we look towards trying to operationalize a lot of these new innovations with our partners and then hopefully optimize them, I think it's just important that in industry we recognize that there really isn't going to be a one-size-fits-all solution. So we have to take into context the unique needs of each institution. They each have their own unique market dynamics, populations they're serving, et cetera, and that all has to be baked into kind of a deployment and sustainability strategy. And then, lastly, I think, and this is the thing that really keeps me up at night, every night, is that without a lasting, sustainable economic model, these innovations will not be able to continue. So as industry, we need to really be focused on working to get reimbursement models in place that reflect the value that these new innovations can deliver, so that ultimately providers will have their incentives aligned to continue to adopt and use these tools that do have demonstrated efficacy and that have demonstrated value.
Yeah, and the issue of sustainability is, as you've emphasized, is a key one, and it leads quite naturally into the third pocket of information that we hope to get into, which is risk. How do we begin to handle issues around clinical appropriateness, around reimbursement, regulatory concerns, and equity? Alistair, do you want to take a stab at that initially?
Yeah, absolutely. I mean, if you look at something like even virtual visit, which has had an extraordinary increase in utilization over the past couple months, something we were doing maybe 1,000 to 2,000 times per month is now somewhere in the order of 240 to 250,000 times a month for a Mass General Brigham organization. But even just the video visit takes, as you think about when is it clinically appropriate to perform a video visit as opposed to an in-person visit. Video visits sit somewhere along the continuum between a chatbot, as Adam was discussing, an ER portal message, an e-visit, a telephone call, an in-person visit, somewhere along that continuum of kind of increase in engagement and presence of the patient is where we have video visits. And it obviously in some ways it improves the ability to inspect the body language of the patient, to visualize, for example, a wound that's healing after a surgery, to have the patient show the clinician something, to understand the surrounding environment of where the patient's located. So information around the patient can also be helpful. And also in some cases, potentially to be able to meet family patient members and their proxies. Video visits also makes it easier to add additional care team members to the visit, whether it be medical language interpreters or consulting clinicians. And probably underappreciated is the fact that video visits also allow the patient to see the expression of a clinician providing information about whether a test is reassuring and positive or not. I mean, if there was no value in video visits, we wouldn't be having conferences going up at such a degree. But we need to take into account the fact that it's not only just clinical appropriateness, but it's also the regulatory and reimbursement and avoiding the scenario by which we hardwire disparity within how we pay for the care for our patients. So if a patient is unable to get onto a video platform, for example, because they either don't have the technology, because they can't afford it, or they don't have the know-how, or it's just not a convenient place if they're a family of 10 in a 2-bedroom apartment for them to conduct that video visit, we need to still be able to fall back on other modes of communication like telephone visit that's still synchronous, but in those cases between telephone and video, still pay the same for those visits so that we don't hardwire that inequity into it. So those are some of the things that I think we need to be worried about as we scale up this technology at this unprecedented pace.
And one aspect that I think you've emphasized nicely, but which I would emphasize a bit more in just summarizing, is the remarkable flexibility in what some of these platforms can offer in terms of adapting to an individual patient or an individual clinical team's needs. So I think that's certainly a strength here. Adam, do you want to provide some additional comments on the risks, particularly around issues like reimbursement?
Thanks, David. I think Alistair nicely described the really astronomical increase in telehealth use that we've seen. In fact, some would say that we've had years of work happen in a matter of weeks. That's truly been remarkable. And my biggest concern, the biggest risk is that we will lose this digital transformation in health, and lots of that may be due to reimbursement. As you know, before COVID, there was really limited reimbursement for telehealth. And now, as COVID has entered, some states and some insurers have agreed to cover telehealth services at parity with inpatient. And I think that has further fueled the adoption of telehealth. And the big question is whether that will continue after COVID. And so I think we have a real opportunity right now to learn from our experiences during COVID, understand where telehealth worked well for providers and for patients, understand which conditions are appropriate for telehealth use. And then it is my sincere hope that we can work with federal and state policymakers and insurers to really find the right balance, to be able to offer telehealth services when appropriate and to find the most appropriate reimbursement to incentivize their use.
Yeah, so a theme that's come through in what you've said and was touched upon by multiple of the panelists is sustainability. What are those key features that must occur in order to sustain the kinds of innovations that have occurred? So maybe with that in mind, we can go on to the last portion of what we hope to get to, which were that there were multiple assumptions about what digital health could do, and multiple ways in which adaptations occurred over the last 2 months. And so I wanted to explore some of that, because some of the assumptions have not proved to be true, and others have proved to be true. So Lee, do you want to take an initial pass at looking at what those assumptions were and how people have adapted?
Yeah, thank you, David. You know, I think we had some assumptions, and they were probably really prejudices or biases. For example, that older people wouldn't accommodate to video conferencing. They wouldn't be able to handle the technology, or that people who spoke a different language than English couldn't be served. I'm fond of saying if my 85-year-old mother can do Pilates over Zoom, we can do virtual visits with many of our patients. I think what we have to recognize is that we were caught unprepared. If you think about it as a medical system, we know that huge numbers of patients have deferred important medical care during this crisis because they're afraid to go into the hospital or their doctors are simply not available. We need to build this video capability, this virtual care infrastructure. We need this to be a permanent part of our health system going forward. This is the equivalent of the National Guard or the Army Reserve, right? We need to be able to deploy capacity at scale on very short notice for the foreseeable future, because we don't know what the shape of this pandemic is going to be like, and we can't afford to curtail our care immediately whenever we have a spike in cases. So I think we have to really explore those assumptions, and as Alistair alluded to, put extra effort into the navigators and the community health workers and whatever we have in society that we can leverage to get our patients comfortable on a digital platform so that we can deliver the care they need through these crises.
Thanks, Lee. Maybe Brooke, could you also comment on some of the ways in which digital healthcare can address some of the inequity issues?
Sure, absolutely. And Lee, I really appreciate everything you said, and this crisis certainly has pointed out the stark inequities that exist. And I think as we look towards adapting and launching new ways of delivering care, we really have to look to eliminate those inequities that have existed for too long and take a real thoughtful approach to questions like how can telehealth really benefit all of society? So, ask ourselves the questions like, can we use telehealth to enable expanded networks, to connect patients to providers that not only understand my mental and my physical needs, but also my cultural needs? So I think there's just a lot of potential for us here to make a really positive change if we approach this new chapter with a mindfulness of issues like this.
Thanks, Brooke. So in the last minute, I'm going to ask Adam to comment, because we've talked exclusively about digital health, but this will have to be balanced with traditional in-person care. How do you see that moving forward, Adam?
Thanks, David. So, I think Technology is not a panacea, and in fact, Lee alluded to it. We have seen patients that have missed heart attacks or strokes and suffered complications because they have not sought in-person care. And so in-person care is still going to remain essential despite the incredible achievements and advancements we've had with technology. And so we need to redesign and think creatively about how to provide in-person care safely for both patients and for our staff. And there are certainly more opportunities for tech to play a role, but we need to ensure that we can deliver safe in-person care going forward.
Thanks. So we are out of time already. This is such a rich topic, but I hope that our dividing it up into these key areas have provided a glimpse of what the major challenges are going to be going forward. I'd like to end just by thanking the four panelists, Alistair, Adam, Brooke, and Lee, for a stimulating discussion. Thank you.